Thank you, Dr. Mustafa, for this is an interesting talk, and I'm sure that this talk will generate a lot of questions, but because of the sake of the time, we'll move to the second presentation, and then we'll take questions for the two presentations together.
Bismillah ar-Rahman ar-Rahim. It's my pleasure to introduce Dr. Luc Noel from France. Dr. Luc was graduated from Geneva University in France and have been specialized in blood transfusions and things related to hematology. And because of his interest, he joined the W.H.O. regarding many issues regarding ethics and transplantations, especially after developing a section of tissue donations and others. And his talk, I'm sure it will be a continuation of Dr. Mousawi's talk, and it will generate a lot of discussions. And he's going to talk to us about ethics of transplantation donation from deceased body according to the WHO perspective. Dr. Luc, please.
Thank you, Mr. Chairman. I would like first to express my thanks to Dr. Faisal Shaheen for his support in the last weeks, and to the GCC Congress on Transplantation for providing me the opportunity to be here and visit the Kingdom for the first time. Ethics of DCD donation, WHO perspective. I shall base my talk on the guiding principles and address donation from deceased person, including DCD, and focus on some ethical aspects of DCD in light of the guiding principles. And very modestly, because part of the idea of this talk is that there is difference between part of the world, between country, between people, between understanding. And if we are in the bandwagon to progress to a common understanding, we have to respect this. Yet, transplantation and transplant tourism, just illustrated, does show that the boundaries around the globe are thin when it comes to a patient to obtain an organ, or when it comes to making money with transplantation. Therefore, we have to reconcile two viewpoints, different diversity around the world, and the need to face a common concern for the globe. And I'll start with guiding principle 3, whom you know very well. Donation from deceased person should be developed to its maximum therapeutic potential. And the resolution that was adopted, the one that endorses the guiding principle, it states that there is a need to have authorities to provide oversight, organization, coordination towards maximizing donation from deceased donor and protect the health and welfare of living donor, including long-term follow-up. Why should we go at maximizing organ donation? To spare the living, we heard this at this, the integrity of the human body, the removal of anatomical constituent, the vulnerability of the live donor, to allow access to other organs than kidney and liver, to meet all needs, to allow equitable access. There are people without related donors. To strive towards self-sufficiency, a necessity to meet all patient needs, to protect society against the danger of commercialism. And the resolution insists, and insisted earlier on, in 2004, from the beginning of the renewal of transplantation program at WHO, it was clearly stated that the use of living kidney donation, when possible, should take place in addition to deceased donors. Now, this is the Global Observatory for Donation and Transplantation. These are 2010 figures, and they show you the number of kidney transplantation per million population for each country. In green, kidneys from deceased person. In pink-orange, from living donor. The dotted line is half the incidence of end-stage kidney disease in the country where it is known the lowest. Let's say 110 end-stage kidney disease per year, as in Norway, for example. And we're close to meeting half the incidence. And we know we're close to meeting the needs of those people with incident end-stage kidney disease that could be transplantable. We can do this by making the best of all resources. And non-heart beating donor is one, and one that was introduced to the World Health Assembly as early as 2008, when we start pushing the guiding principles to the executive board. And in the note from the Secretariat, it was clearly mentioned that there were two approaches. One is the withdrawal of patient life support system. The patient vital function ceased and death has been declared. If authorized by law, if authorized by the patient's next of kin, by the patient's own previously expressed wishes. The other one is the death occurs unexpectedly. And there are some countries, we recognize from our consultation process, that in some country, steps can be taken to prolong the opportunity to obtain transplantable organs. What came up from the consultation process at the time was that the techniques used to preserve organs need not involve complex technology, particularly where only kidneys are concerned. Programs that use non-heart beating donors are therefore accessible to countries with limited resources. But there is a but. I skipped this, that's the, as well as, well, I can use this one. Dr. Rowinsky has provided an extensive background this morning and already outlined the complexity of the topic. With the controlled and uncontrolled donation from non-heart beating donors, there is that diversity among countries. Europe is a wonderful example of countries which are rather close in terms of economic development, and yet there are drastic differences in their positioning unto donation from non-heart beating donor. That is the reason, when elaborating in that global endeavor where Scott and Dr. Shaheen were at the front, the critical pathway. This led to careful wording. The potential donor in the branch of donation after circulatory death. On the other side, donation after brain-based death. Worded as a person whose circulatory and respiratory function have ceased and resuscitative measures are not to be attempted or continued, or a person in whom the cessation of circulatory and respiratory function is anticipated to occur within a time frame that will enable organ recovery. Careful. And likewise, that same document, this time, punch in something that is a vital protection. It's the dead donor rule, which must be respected. Patients may only become donors after death, and the recovery of organs must not cause donor death. Guiding principle 2, no conflict for death determination. Physician determining that a potential donor has died should not be directly involved in cell tissue or organ removal from the donor or subsequent transplantation procedures. Well, conflicts of interest and national authority are requested in the commentary to set out the legal standards for determining that death has occurred and specify how the criteria and process for determining death will be formulated and applied. And that's where, through our consultation process, we had the feedback that guidance on the criteria to determine death, a reference, a global reference, would be helpful to many countries. And the WHO project towards guidance for the determination of death aims at this, trying and achieving global consensus and standardization in the principle and criteria used to determine death. And these must be applicable whether or not, of course, organ donation is considered. And it should be independent of available resources. That has been initiated to anticipate and respond to expressed requests of member states to ensure public confidence in the way death is determined, to protect the public healthcare professionals and society and contribute to optimize patient safety, to uphold the dead donor rule, the dead donor principle, while contributing to reducing the reliance on living donation. And we had a first meeting with a restricted but high power, and the names you recognize. We had the best experts from China, India, the US, name it. That project is on hold for lack of funding of W.H.O. and my unit. But the conclusion of that first group were quite clear. There may be several ways to die, but only one to be dead. The irreversible loss of brain function, that's Christopher Pali's sentence. Permanent cessation indicates that the function will neither return spontaneously nor will it be restored medically. Irreversible cessation indicates that restoration of the function is impossible by any current technology. And there was the recognition that on current evidence, it's difficult to be confident in defining the time of circulatory arrest required before loss of brain function becomes irreversible. The issue is defining permanence, and that is meeting the reality of practices. There is a separate issue in determining death and allowing to die, matching reality and available, suitable use of health technologies. In fact, we all know there are by far enough viable and functional organs at the death of the person to meet all needs. The question is, how can we, in a transparent, respectful, ethical manner, recover them? And the difference between death based on neurological criteria and uncontrolled DCD is obviously in the time and the need to quickly refrigerate by flushing, by peritoneal refrigeration, or by focalized ECMO the organs. The Spanish, and I have been given a few slides by Rafael Matezans, in Spain DCD2 and controlled is it takes 3 to 4 hours of warm ischemia, and they have good results in kidney transplantation, but also in liver and lungs. The cause of death in Spain, you'll see that this is relevant. The cause of death in Spain for organ donors, and that includes the 8.6% of all the organ donors coming from DCD, uncontrolled DCD. The road traffic accidents have dropped down, cerebrovascular increases, and other increases slightly, including the DCD2. Road traffic accident decreasing, this is the trend in all developed countries. These are EU figures. But also cerebrovascular accidents. Cerebrovascular accidents are decreasing in Europe. And in all countries, with differences from where they came from. Why does it increase in Spain? It increases in Spain because the age of donor is increasing. And this is the organ donor age between 92 and 2010. And you can see that there's 40% of the donors above 60 years old. Another factor that pleads for the decreasing of brain death is decompressive surgery in the treatment of malignant infarction. And that's where the exchange between brain death and the possibility to donate as DCD-free, controlled non-heart beating donation, comes up. And you will see that differences between countries, just like I showed you before, exist here. In the ETICA study, dating back to 2003, but querying intensive care units about their practice, withdrawing life-sustaining treatment varies enormously from 47% to 18%, and a gradient north to south or I should say south to north, in accepting withdrawal of life-sustaining treatment. And the same patient, in fact, can be dealt with very differently, arriving in an emergency room in different countries and with different resources. He may be left to die after assessment in the EU without donation. In another poor countries, not having ICU facilities, and I noticed Dr. Shaheen reference to the need to have dedicated ICU beds for donors. The family may be given an ambu bag, and there is and some are doing it, room for DCD, where at the moment the family is exhausted, roughly. That same patient could be knowingly planned to become a controlled DCD after withdrawal of ventilation. But that same patient could also be transferred to intensive care until brain death develops, and then be recognized and provide the quality of organs that would be perfused as you would expect in DBD. And last but not least, in some countries, the lack of identification of brain death or the lack of systematic attention to the resource available in ICU leads to death without donation. So that spectrum is a reality. There are questions in controlled non-heart-beating donation, questions requiring clarity, and clarity is the basis of ethical choices. The first one is, it's important, of course, to affirm the independence of the decision to withdraw care from the decision to donate. This belongs to the clinicians. This has nothing to do with the need for organs. It is, in fact, it is a reality in many ICU who are making the best of their resources, because that dimension is important. The second is appropriate level of consent to pre-mortem measures. Pre-mortem measures coming from simply having death taking place in another area, let's say the OR, than the ICU, or testing ventilator dependency, or heparin. That's one before the death, before withdrawal of care, is a question. Cannulation of femoral vessels to ensure swift refrigeration is another. What's the consent there? Knowing that you would expect the interested person, as well as this next of kin, to accept this, and you could think that if someone has expressed the need to be a donor, would just be retrospectively in another world happy that things are done as well as possible to preserve the organs. Some would argue against this, and it needs to be taken on board. The consent in general, and that's guiding principle 1, will stress in its commentary, and I want to underline that sentence. It is important that the public understands and accepts the process of donating cells, tissue, and organ, and that is that these understanding and acceptance should be deep-seated and unambiguous, deep-seated and unambiguous. And that's a key to ethical process in non-heart-beating donor. Public understanding, I mean, this, you may have seen this slide about self-sufficiency. Self-sufficiency relying precisely on developing donation from deceased donor to its maximum, because the resource is here. Because it can only be seen as a good deed to have organs that are not needed anymore used to prolong the life of other living individuals. And developing donation from deceased donor needs to be taught, and taught in school curriculum simultaneously to the prevention that would reduce the needs. The Madrid Resolution on organ donation and transplantation, that national responsibility in meeting the needs of patients, has a headline which reads as opportunities to donate should be provided in as many circumstances of death as possible. And that leads to the idea, to the concept, the opportunity to donate is part of best practice in end-of-life care. Guiding principle 11, transparency and confidentiality. Transparency and openness to scrutiny, always a safeguard, and particularly in this matter. So, in conclusion, a few points. As there are potentially enough viable and functional organs at the time of death of the deceased person to meet all patient needs, developing DCD is the way to improve organ recovery, considering the limited number of brain-based death diagnoses. The dead donor rule is essential. Care decision and determination of death must be independent of donation. And they are. Yeah. It remains to build up the system to realize donation. Special attention is necessary to meet consent requirements according to the law, and in any case, to explain procedures to the family. DCD implies actively seeking that deep-seated and unambiguous understanding and acceptance by the public and by healthcare professionals. DCD programs are specific to each context, of course. The level of advancement of the healthcare system, the population awareness, the country tradition, etc. The opportunity to give one organ should be seen as part of good practice in end-of-life care. And proactive transparency is a safeguard. Thank you.
Thank you, Dr. Luc. And may I ask Dr. Mustafa to come up for answering maybe some questions. So, any questions from the audience, please? Both papers open for question. Yes, Dr. Matri, please. Press the button.
One.
Yes.
Yeah. Thank you, Dr. Mustafa, for your presentation. It's very wise recommendations. But we showed that people, non-related donors, give more when they are foreigners, non-Kuwaitis. And do they donate to people from the same nationality or in a pool?
No, this is not non-directed, this is directed. So a donor, a recipient or a patient brings the donor with them to the committee. Now you say, why do you have more non-Kuwaitis? Because in Kuwait, 2/3 of the populations are non-Kuwaiti. So it is obvious that you get more donors. And of course, the non-Kuwaitis have got a lower standard of life and they are poorer than the majority of the Kuwaiti. So I think that can explain the large number of, for example, Egyptians and Syrians. And these are poor people who are forced by their poverty to donate. They, of course, they claim an emotional relationship, but I don't think there's any emotional relationship between the recipients and the donors. So it is not, in Kuwait, until now, we don't have the rule that should be from the same nationality. If we apply this rule, I think we can reduce this business to a minimum. But the Minister of Health, under the pressure from the patients and by members of parliament, are not doing that.
The Egyptians are the majority. So, but the recipients are not Egyptian.
No, recipients are majority Kuwaitis.
Kuwaiti?
Yes.
So, thank you.
Any further question? Yes, Faisal. Okay, please, go ahead. Domenico.
That's fine. Luc, I wish to bring to attention a comment, and then perhaps your comments, but you're aware of this already because I wrote to you about this just a few days ago, having just come from China, and your point about how DCD programs have to be in the context of the society. But I wish to say a very commending word about China in their transition to the death diagnosis that's completely exclusive of the executed prisoner. They're recognizing that they need to do so. So if I may, Mr. Chair, just 30 seconds, what this protocol is. It is an individual that has a devastating brain injury and then is determined to be brain dead. And then they take this patient, in which they cannot legally declare brain death in China today, to the operating room, and they withdraw the pressors. When the blood pressure comes to 90, they implement ECMO so that they can preserve the organs. Remember now, this patient is brain dead. So they can make that maneuver, ethically as far as they're concerned, because the patient is indeed brain dead. Even though it's not legally sanctioned, they medically apply the criteria. So when the blood pressure is 90 and now it's falling and it will come to 0 ultimately, they institute ECMO, stop the respirator, wait until a time in which the EKG is flat and there is no respiration, and then by the standard of the country, they declare death in that there's an absence of circulation, native, and respiration. I find it to be a quite innovative, plenty smart protocol. And perhaps your comment about this, I think that this is the application of DCD in a way that we hadn't thought about, and to me, it could be a very important contribution.
Of course, that's an illustration of the diversity, and thank goodness we're not alone, because as you say, we didn't think about it. What's taking place in China is indeed absolutely remarkable. I cannot measure how much the people are associated to it, but I know it's a concern for those who are promoting this idea, and they are involving media. I do hope this example will be replicated with their own way, their own approach, and that can be very rudimentary. I'm thinking about what Elmi's been able to do in Cape Town in conditions of constrained resources. The fact is, there is a reality of death, there is a reality of patient needs, there is a common humanity, a group of human beings, and communicating in a way, facilitating, making it well understood that this should take place is the goal.
I have two doubts which I would like to share with you. One is whether controlled DCD will not become the preliminary step to use organs from patients who died due to euthanasia, which did happen already, as you know. And the second doubt is related to your talk, Mustafa. I'm against payment, but if we are restricting on autonomy of the living person, why don't we agree to restrict autonomy of the dead person and take organs from everyone, except from those who clearly said, I do not want to?
Yes. Patients that have been requesting and have been granted euthanasia, willing their organs to prolong the life of someone else, it has taken place, yes, indeed, and I think there are two things to be reminded at this stage. The first one is the dissociation between the clinicians, the healthcare system, the population choice of, that's another of those country tradition and or understanding of facts of life. The second is that the transplantation community has a responsibility and may sanction the use of a deceased person when it disapproved the way that person has died. Think about the executed convict. Would this be a similar situation? Not sure, because there has to be it needs to be debated, but I know it's controversial. It's probably not black and white.
Wojtek, as regard to your comment regarding the making it obligatory for people after death to donate, I think this is very interesting. Of course, we are talking about presumed consent, which is being applied in many European countries, but in our part of the world, as far as I know, is only Tunisia. They have the law permitting presumed consent. In Kuwait, we have been pushing for such a law. In fact, interestingly enough, we have a religious decree, a fatwa, which says clearly, if somebody is dead and somebody is dying, you can take organs from the dead and give it to the dying, even without the consent of the relatives, even if they object, because here you are saving a life. And according to the verse in the Quran, whoever saves one life, it is like saving a whole nation. وَمَنْ أَحْيَا فَكَأَنَّمَا أَحْيَا النَّاسِ جَمِيعًا. So we have the backing of fatwa or religious decrees, but still most people will not accept, or the public might not accept, presumed consent.
May I only ask, the guiding principle of WHO says that the public acceptance is of extreme importance. The public accept the transplantation. Now the public probably should understand that there is no transplantation without the organ.
Okay, this is a comment, okay. No, you are not. I think this is a very important issue. If we can apply presumed consent in this part of the world, I think that would be a big step forward, because we are really lacking behind regarding deceased donation. We are on the bottom of the list. All Middle East countries are on the bottom of the list. By introducing presumed consent, we can do something. Although, to my knowledge, in Tunisia, they have a law, but still, people will not, will not accept donating despite the law.
Yeah, I guess this session is very interesting and generate a lot of discussion, but because of the sake of the time, I am afraid that we have to end this session. But of course, the discussion can continue after that with all the speakers. That we thank them all for coming and giving us this informative sessions. Thank you all for attending this. I think we'll go for a break and then we resume at 4. Okay, thank you all.